Dr. Nosa Omoruyi. So I'm just going to go ahead. You know, you guys have to know that when you have the honor and privilege to have such a renowned person, we really need to appreciate him. So if you can stand up. So I'm going to start by giving a very brief bio for Dr. Nosa. He is a consultant child and adolescent psychiatry at the Schunecker Clinic, Scarborough Health Network, Centenary Site. It's very long, so listen carefully. He's a physician for the Early Psychosis Intervention Program. He's the lead physician, Transitional Age Youth Program, that's the link, Scarborough Health Network. He's a lecturer at the University of Toronto. He's also a consultant psychiatrist at Lake Ridge Health Ajax site. I didn't know that. Dr. Omoruyi had his training in family medicine, general psychiatry, as well as child and adolescent psychiatry. He has practices at Lake Ridge Health Ajax and Scarborough at the Centenary site. He also provides care to individuals with complex presenting mental health issues in private and public residential treatment centers in the GTA. He has special interest in mental health challenges in transitional age youths, as well as neurodevelopmental disorders in children. He is married with a wonderful family and enjoys road cycling and other sports. He's also a leader and a deacon in his church. So please welcome him. You can go up there.
I just want to say thank you to everybody. I want to start off by thanking Pastor Victor and Pastor Patty Rabo for inviting me and showing me this honor. Can you all hear me? Yes. Okay. I want to thank the members of congregation who found time, to come to church today. I really appreciate. Without much more ado, so you've heard a brief bio about what I do for a living. I just want to emphasize that I came into psychiatry after practicing family medicine for a few years in my country. So I think that at first it looked like a disadvantage because you had to go back to school here for donkey number of years. But looking back now, it gives me the type of perspective that most of my colleagues don't have in this field of psychiatry. So I'll be here today to hopefully share some wisdom. The Bible says that in all that getting, get wisdom. Wisdom is the principal thing. So my goal is not to obviously lecture. My goal is to share, what I know and then listen to, questions that we might have and, just rub minds together and provide some insight from a medical perspective. So I'm looking forward to chatting with everybody. And I just want to say thank you once again for inviting me and for listening to me.
Thank you. So how we're going to run it, there's a basket at the back. People can write questions down, and while we're discussing, if you do find that you have questions, you can always raise your hands, we'll bring the mic. I do have some questions here that I think we'll just start to get the ball rolling. The first question is, how can we destigmatize mental health among Christians? So Christians also suffer from depression, anxiety, but are afraid to seek help as they feel they will be looked upon as someone without faith? So if you can.
Thank you so much, Dr. Victoria. That's a very important question, not just for the Christian community, but for everybody. Psychiatry, for as long as I remember, has always been stigmatized. And, you know, part of the problem is us physicians, you know, and also the society, particularly the popular media. A long time ago, we called people with mental illness lunatics. It was an official name, and we put them in sanitariums, right? We put them in a special place out of the city and locked it up, right? Can anybody guess, just as far back as maybe 5 years ago, if you had a child or a family member who was intellectually slow, you know what we called it? Thank you. Isn't that judgmental? Yes. So, because you get kids who say, I don't want individualized education plan. I don't want a doctor because everybody will call me a retard. Only recently, with the advent of DSM-5, just about 3 or 4 years ago, did we feel it necessary to change the name to intellectual developmental disorder, because it's a disorder, and it's not a character thing. So stigmatization has been in psychiatry for as long as psychiatry has been in existence. And I think that we individuals, we have to recognize and come to the realization that mental illness is a pathology, is a disease, is a disorder that has a specific cause, runs a particular line, and is amenable to intervention, just like any other illness out there that you may have. Can anybody tell me, just a guess, if you, let's say you have a family doctor who just relocates to Ajas and sets up practice, take the population of those who will see that doctor for the first 6 months. Can you just hazard a guess, the most common diagnosis that that doctor will be dealing with, or the most common reason for visiting that doctor? Top 3. Anxiety. Anxiety. Depression. ADHD, yeah, very common. That's up to 20% in school-age children. Thank you very much. So this is something that is quite common, and it's something that we'll have to learn to start to understand that it is more genetically determined. For example, anxiety and depression, there's more genetic footprint for these illnesses than hypertension and diabetes put together. Obviously, I'll be talking a little more later, but the conclusion is that stigmatization is as old as psychiatry itself. Unfortunately, a big part of that has been us doctors, but I think that there's concerted effort now to change names, to change approach, to make it more palatable, to make it out there in the community that it is really no different when you are suffering from clinical depression than when your blood pressure is high or when your sugar is excessive. Indeed, I take medical history and family history more seriously in the so-called mental illnesses and physical illnesses because, like I said, the genetic footprint in mental illness is nearly always there, including addiction and mood and anxiety disorders and psychotic disorders compared to the organic illnesses. I hope I have tried to answer your question, but if you still have more, please be kind to write it out.
We have a lot of questions.
Okay.
Okay, so I'm going to try my best to actually put them together because these two seem to be similar. How do you identify anxiety, and what is the best way to deal with it? This one is also, how do we recognize being anxious to actually having severe anxiety, and how can we treat it? Then can you improve your mental health by changing your diet?
Thank you. I'll start with the last one so I don't forget. Yes, you can absolutely improve your mental health by changing your diet, your lifestyle, including being more physically active. Indeed, I always say that a prescription for exercise, 20 minutes a day, 3 to 5 times a week, is more powerful than 20 milligrams of Prozac Prozac being one of the more popular antidepressant, anti-anxiety. It is not a joke, it's for real. But I qualified that by, let me circle back to the question again. It depends on the severity of the illness. So, for example, if you have a little bit of high blood pressure, if your blood pressure is 130 over 90, 140 over 95, well, yeah, and you have, one or two things in terms of lifestyle that you can change. You can lose a little bit of weight. You can switch from being sedentary lifestyle to more active. You can decrease salt intake in your food. You can decrease stress by, confronting, all the things that we all face in life. You do all of those things steadily. Will your blood pressure come down? Yes, absolutely. Would you need medication? In all likelihood, you won't. But let's say you have blood pressure that is 180 over 120, and you have suffered, let's say, consequences like, heart enlargement or kidney damage or damage to your eyes. At that point in time, common sense tells you that this is not dietary anymore. This is not changing lifestyle anymore. This is something that you need maybe medication or other intervention to help bring down. How do you recognize anxiety? So we're all anxious. Anxiety is just part of our makeup. It is protective. Anxiety is very loosely defined excessive worry. Maybe a little more nuanced definition. You could see anxiety as fear of the unknown. There are many synonyms, excessive worry or nervousness or worryworth or whatever you want to call it, right? It becomes a problem when it switches to being anxiety to a disorder. When does it switch from anxiety to a disorder? When it affects productivity. Whether it's you being productive in school as a youngster or you being productive as an adult at work, that's the main criteria. When it starts to interfere with your ability to function as a human being, it switches from regular worry to a disorder. A disorder is something that is chronic, does not respond to regular interventions, and is associated with a major dysfunction in occupation, in social life, and in your productivity. When that happens, usually that's the third or fourth criteria in the way we define it, then you call it a disorder. If that piece is not there, so you would often see doctors say unspecified anxiety, or you will see doctors say situational anxiety or situational worry, or doctors use, language like that that tells me when I'm reading, that this person is still able to go to work, run their family, do their recreational things, but the anxiety comes up once in a while. So that's what differentiates it. How do I recognize it? So you have to have a trained eye. You have to have the antenna. You have to be looking out for it. You have to be trained to pick it up. It took me a little while to just listen to somebody for a few minutes, and I can recognize the signs and symptoms of anxiety. There are specific signs and symptoms of anxiety, and once you start to talk to the person as a clinician, you can easily pick it up. There are screening tools that are available if you wonder whether or not you have the problematic type of anxiety. And the most popular one, and it's freely available on the internet, is GAD-7. So Generalized Anxiety Disorder 7 Symptoms-7. So if you put it in your browser, GAD-7 PDF, you're probably going to see it, and you can screen yourself for it. Now, that you screen positive does not mean you have the anxiety. You have to have a professional evaluate you to now decide that, yes, that you actually, because your anxiety may make you screen high or may make you screen low. So you have to have somebody else who will talk to you and help you pass it out to actually say, yeah, this is a problem and here are the options for treating it.
Okay, so you guys don't have to do that now. So the next question, I have 4 different questions here, all relating to sleep. So I'm just going to read them quickly so that the people will appreciate that we've read their questions out. Is sleeping with a sleeping machine, does sleeping with a sleeping machine add to our health with mental issues? Can my body can sleep, but my mind is that sometimes to be worried about. How do I do? So maybe they can't shut off their mind, but the body is tired. My body can sleep, but my mind can't at times. Is that something to be worried about? How can I deal with it? And somebody's also asking, is sleep paralysis a symptom of anxiety or depression? How do we fight sleep paralysis when you're experiencing an episode, and what are the So that's a big question on sleep paralysis. And I'm sure, you know, when they're pressing you and you say it's spirit.
Okay, so thank you so much, Dr. Victoria. So interestingly, this is something that I dealt with as a person growing up in medical school. So I remember I went to my mom and I complained that, you know, I'm going through these episodes where it looks like I'm awake but I can't get up. Or it looks like, you know, I'm conscious but I don't have control of myself. And, you know, this is our son in medical school, and of course she says, oh God, they're attacking my son. So sleep paralysis is a sign and a symptom, a cardinal sign of a primary sleep disorder. If you have sleep paralysis, don't be afraid. There are many things, but maybe just two possible outcomes that are very common. And they're all related to a sleep disorder, primary sleep disorder. The number one, and probably one of the most common, is a condition called narcolepsy. So in narcolepsy, people will just have this irrepressible urge to fall asleep and just drop down and sleep. And if you let them sleep for about 1 hour, they'll wake up, feel refreshed, and they're ready to go again. But during that period where they feel they must fall asleep, they can have these things that we call, they're big names, but I'll explain them. They can have these symptoms that we call hypnagogic or hypnopompic phenomenon. So, okay, so hypnagogic is when you feel, so the sleep paralysis, for example, when you're like going to sleep and your body feels paralyzed, that's hypnagogic. Hypnopompic is the same phenomenon occurring when you're trying to wake up, you're conscious, you want to wake up, but you can't wake up. All of these things happen in the first phase of sleep, the REM sleep, the rapid eye movement part of sleep. If you ask your family doctor to refer you, if you have this phenomenon, don't be afraid. Ask your family doctor to refer you to a sleep clinic. I can assure you there is very specific medication that is based on very good science. I can go into details. Very good science that will fix it and you won't have to deal with it again. There was another question about sleep and not feeling relaxed. So the most common reason for insomnia are mood and anxiety disorders. I learned this the hard way in residency training. I always thought that people who have insomnia have primary insomnia. It's a very common, tricky question in medical school. What is the most common reason why this person is not falling asleep? Mood and anxiety disorders. We can't shut our mind down, or our mood is low, it's very, very low. Or we're just constantly, you know, our mind is just chiming like broken CD or broken record, unable to shut down. And when we do fall asleep in that state, we don't experience the first phase and the second phase. The second phase is divided into multiple phases of sleep. We don't go through gradually the way we're supposed to go through. So our sleep is interrupted. And so we miss many stages. For example, you may just go straight from, you know, just being awake to stage 3 and stage 4 sleep, and you don't have REM sleep. And then you wake up feeling unrefreshed. You wake up feeling unrelaxed. You wake up feeling unfulfilled. And that can continue for a long while, and that may impact your head. There was a last question about Cpap machine. So if you do have a Cpap machine, I encourage you to use it, because if you don't use it, you're going to end up with, cardiac abnormalities, particularly the right side of the heart. And there's no treatment for that. So if you have hypertension on the right, that is coming from the right side of the heart, there's no, it's very difficult to manage, let me put it that way, compared to hypertension that is coming from the left side of the left pump of the heart. Thank you.
Thank you very much. The questions are coming. So I'm going to put these two together. How do we help someone struggling with grief for many years? So that's the first part, and I'm just going to add this one. What should the church's role be in supporting mental health?
Thank you so much. So, thank you. So grief, how do we support somebody with grief, struggling with grief for many, many years? From literature, the best way to provide support for grief is group-based treatment. It is more effective than individual intervention. But combination probably helps better than either. So a group-based approach and an individual approach to dealing with grief. One of the most common reasons why there is no resolution of grief is that the individual may be having difficulties with accepting what has happened as what has happened, or other stages of grief that the person has not been able to move over or move across or overcome. Grief is divided into multiple stages, and the stages don't necessarily occur one after the other, but one important stage is acceptance, and depression and feeling sad, and low motivation and just difficulty regaining your what I call mojo in life. Is all part and parcel of the depression part of grief. So I would say, with respect to support, I think that a Christian family like we have here, very good place to start. I think coming forth and discussing it and opening up about your struggles, I think that individual counseling using scriptures can definitely help this individual. I also think that a group as maybe available in the community can help. Most of these groups, they're not religious in nature. They're very helpful. One of the more popular places in town is the COPE, C-O-P-E, mental health. It is run from the mall, the Whitby Mall. It's been around for a long time. I used to know the individual who ran it. He's not a manager there, Derek. He's been around for more than 15 years. They do have a grief counseling. I have referred many people there. I totally recommend the COPE Mental Health in terms of accessing the group format for getting help and counseling for grief.
Very much. The next question is, how do you handle it if a child says he is stressed mentally or unhappy? That's number one. Number two, do children have mental stress or ailment, and why? And how can a parent handle it? And how do we know a child is mentally stressed?
Thank you very much. This is my bread and butter, being a child and adolescent psychiatrist. So do children go through stress? Absolutely, all the time. How do we recognize it? Most parents who are very intuitive, they would recognize it. How do you manage it? So many ways to deal with it. I think one of the first 30 signs that a child is struggling mentally is their productivity academically and socially. The reasons why a child may be stressed, they are numerous. top 5, in my estimate and based on my practice, is pressure from school or pressure from parents to perform in school, peer pressure. Other things could include things that we all know, such as bullying in school, that a child may or may not, disclose to you. Conflict at home probably should go higher up there. Conflict between parents. So when you're talking to your spouse and you raise your voice and you think that little Johnny is playing video game and he doesn't listen or he's not understanding, he picks it up and he reacts or has reaction to what's going on that you may not want to acknowledge. One of the more prominent and maybe devastating impact on kids is occurs when parents separate, not just the separation, but acrimonious separation. When the separation is associated with a lot of acrimony and a lot of verbal and physical issues going on, no matter how you cut and dice it, kids always come out impacted. So doing the assessment and figuring out what is causing, what is responsible for a child who is stressed is multifactorial. My suggestion is if you recognize that your child is not functioning at their baseline, or they're struggling academically, they're struggling socially, or their behavior or character is out of tune with how you've raised them, and you can't seem to figure it out, or you can't seem to find a way to deal with it, I would say don't be afraid. Get counseling or seek referral to a psychiatrist or get that person assessed. That you see a psychiatrist, particularly a child and adolescent psychiatrist, doesn't necessarily mean that your child is going to be put on medication. And even if they say, I recommend medication, you can say, no, I don't want medication. And you can say, can we try this first? Can we try this first? And can we try this first? A lot of the time, when you give that child opportunity to interact with a professional, they will say things that they've never said to you, the mom. They will disclose things that you didn't know was bothering them. And for many reasons, it could be that they don't want to bother you as a mom. You're already carrying too much. Look at what is going on. I didn't want to bother you. Or, well, if I told you, you're probably not going to take it seriously. Or if I told you, you're going to tell Uncle John. And I didn't want Uncle John to know because you never keep my secret, right? And you find out that when you avail the child this opportunity, that intervention, it may be 1 meeting, 2 meetings, 3 meetings, 4 meetings, it changes the course of that child. It could be 6 meetings, and then no medication is needed, and they just fade out of treatment. You don't see them again, and then you hear maybe from the parent 6 months later, 1 year later, how is young man doing? Excellent. He's fine. He's back to his baseline. He's doing quite well. Just 2 or 3 meetings or 4 meetings. Doesn't have to be with a psychiatrist. It can be with a counselor starting from school.
I know our time is running up, but I have a very important question here. The person says, thank you. Does social media play a huge role in negative mental health?
I agree. I totally agree.
And do you think instant gratification is a role player in mental illnesses? If so, what could it cause?
I totally agree. We all seek gratification, and social media gives you that instant gratification. But the parameters may be faulty. So instant gratification from social media is not real. It's not life. It's not sustainable. It pushes you to continue seeking this gratification and extends the boundaries of your upbringing. If you were raised to not do one thing, you find out that because you're looking for this gratification, you're doing it. You're doing it. You're having communications with people that you shouldn't be having communications with. You're using languages that you were not raised to use. Social media is a big problem. And I always say, monitor your children's social media account. You have to. It is not a breach of privacy. It is common sense. You may say, I'm not knowledgeable. Well, talk to somebody who is knowledgeable so that their account is your account. And you can pick up that device and look at what they're doing, and you say, this is not going to happen again, or this is not going to happen again. Because, see, somebody once said to me, if you allow somebody else that is not of your approval to talk to your children more than you do, sooner or later, they'll put up the character and the belief of that person.
Thank you very much. The same question again, and it's in twofold. How effective is medication in relieving mental illnesses? And then another person asked, someone with mental problem, do they have to take medication for the rest of their life?
Thank you so much. How effective are medications in treating mental health disorders? Very effective, extremely effective. So if you piggyback to what I said earlier, think of it in a very common sense way. Think of it this way. Mental illnesses occur in a spectrum. It's not cross-sectional. It's not like I see you right now, you're having a panic episode right now and that's it. No, it occurs in a continuum. And most mental illnesses wax and wane. So they have episodes and periods of remission and relapsing. So basically, they come and they go, and they come and they go. The problem is that in between, you may be okay, but if you do have a relapse, and the relapse lasts for 6 months, and you're a first-year student at University of Toronto Scarborough campus, and you pull out, because you can't continue, your life has already been interrupted. This is what I say to the parents that I see. Your kid has attention deficit hyperactivity disorder. It's very obvious. They winged it through every transition in their life. When they transitioned from grade 8 to grade 9, they winged it through. You knew. You saw all the reports. You know what I'm talking about. They winged it through from grade 11 to grade 12, and now from grade 12 to get to the first year university, and they're falling apart. And you're still sitting down there saying, doctor, I don't want medicine. I don't want medicine. Okay, fine. When you do decide to have medicine come. So the medicines are extremely important in very select cases, and those cases are situations where the severity warrants the medication intervention. Mental illnesses occur in a spectrum. At one end of the spectrum, an intervention you need is behavioral. At another end of the spectrum, you need both behavioral and pharmacology. And the medicines are extremely, extremely safe. In the past, maybe 40 years ago, 50 years ago, I can't say the medicines are safe. I can't. These days, most of the medicines that like doctors and psychiatrists like me use to treat mental illness, they are safe to the point that they are in the same category as Tylenol. Most of the medicines, they are in the same category as Tylenol in pregnancy. They can be used for very young people. They can be used for seniors. They can be used for women who are pregnant. There's data to show that they are safe. The bad press and the stigmatization is what leads a lot of families to just turn their mind off completely and say, absolutely no medications.
Thank you very much. The next question, which again arises because we're in the church, can mental illness be caused by demons?
Thank you so much. I think I should defer to Pastor Victor Erabo for that. But my layman's approach is yes. Right? There are many scriptures in the Bible that tells us that, right? But that doesn't mean that every mental illness is demonic. There's some mental illness that is our own choice, our own poor decision, our own lifestyle, what we've decided to do or not to do. How can you tell the difference? I pray. I pray. Occasionally, you get situations that, as a doctor, you've done everything you know to do. You've put in every intervention you know to do, and this person is not getting better. You've gone as far as you can go, and this person is not getting better. And then you wonder what is going on, right? The diagnosis is crystal clear to you, right? The treatment intervention, you follow the steps as recommended. You've seen these steps work again and again and again on other people. But in this person, there's no response, right? So there's a catchy phrase for it. We use the term treatment refractory. So what's causing treatment refractoriness? Well, your guess is as good as mine. We can speculate. So some people just don't respond, no matter what you've done. They just don't respond, and you just see their costs going down, gradually. Fortunately, these are very, very, very minor. Sometimes there's enough response for the person to have what I call awareness or insight. And in addition to what you're providing as a doctor, they go out there and take care of their lives the way they don't tell you that they're doing. And ultimately, it becomes a more holistic approach, and then there's improvement.
Thank you very much for that, because we do find that in practice. I'm sure the other family doctors in the audience can attest to that. Have questions here. I'll just put them together again. I think our time is going. What's the difference between a diagnosis of depression and just the thought of being depressed? So somebody feels, okay, I just feel depressed. So how do I know I don't have depression?
Oh, thank you so much. Thank you, Dr. Victoria. So clinical depression is a very specific language. So the official terminology is major depressive episode, and it can occur recurrently. So you could say a major depressive disorder recurrent. Each episode can be, moderate to mild to moderate to severe. There are 5 criteria that you have to meet. And again, if you piggyback to what I said earlier, there has to be that major criteria, which is falling apart of your occupational, social, and family responsibility. So you will be falling apart in terms of your ability to take care of yourself, go to work, and interact socially. So when you have that, along with the 5 symptoms, there are 5 of 9 or 10 symptoms. A doctor will just casually ask you, how is your mood? Mood is low. Have you lost interest in things? Yeah, I used to like playing soccer. I used to like doing music. I used to like singing in church. I just sit in the back these days. Okay, have you been having difficulty focusing on consent? Oh, it's just so I can't even read my newspaper or whatever it is. I can't do these things that I do anymore. You ask questions about, feelings of worthlessness and hopelessness. They all check out. And then you ask, of course, questions about safety. And they tell you, yeah, this has occurred to me, but I'm not going to do it. And you ask all of these other questions that just pop into your mind as a doctor. In medical school, I used, because I was still learning, and I used SIGECAPS as a mnemonic to remember all of the symptoms they constantly ask you, but having practiced for so many years, it just sort of comes off you naturally. So once you do all this interview, sometimes you can use screening tools as well. There are many screening tools on the internet that most family doctors, when referring patients to me, they've already completed these screening tools. And then you get collateral information. It's from collateral information that you get things like this person is not going to, is not functioning the way they're supposed to be functioning. They're not taking care of their hygiene. They're not brushing the way they, brushing their teeth. They're not, socializing anymore. You put all of this together and you establish the dysfunction. And then that tells you there's now a disorder. So that separates you from just feeling sad. Just feeling sad, you're just feeling sad, but you don't have a disorder, because you're still able to carry out all of your daily activities.
So as a child, it is hard to tell your parents about problems you may have, because you don't want to burden them with your mental health problems. How do you suggest for one in this predicament to get help?
Thank you very much, Dr. Victoria. That's a very important question. I think we all struggle with this. We're all very busy. As parents, you're going from one end of the city to the other, trying to make ends meet so you can provide for your family. Very often, what happens is, little Johnny at home is just, by himself most of the time, and that happens. What I say is that as much as possible, you have to recognize this. I think that we can all relate to the fact that when growing up, for example, you can leave your home and go out on the street or to the neighbor's place to play and be active and be busy and socialize, right? These days, if you want to have a play date, your parents will drive you to the place. They will stay there and have their cameras and the phone waiting, and then after 1 hour, the play date is over, or 2 hours, and they come back inside. And when growing up, you just go out and you play from morning till evening, and your mom comes out and screams your name in the street, and then you come back home, and you're safe, right? It's not like that anymore. So I think we recognize that's what's going on, and our kids now are just glued to the screen. As much as possible, find that little time. Maybe it's in the morning when you're driving them to school. Say, how are you doing? What's going on? Maybe it's when they come back, you sit down there and say, what's going on? How are you? How was school today? Be interested. At least one parent must be available to talk to this kid and can point out things to the other parent, if necessary, to say, okay, yeah, I think something is going on here, and I think we need to make some changes, and I think we need to do some things so we can be more available to our child.
Thank you very much. Now we're moving to another dimension because I've got two questions. So the first one is, can weed cause mental illness? Marijuana, can it cause Igbo? Can it cause mental illness?
Absolutely.
And then the next one, how do you deal with reinstating a child into normal life after the side effects that comes with the drugs, like laziness, overeating, oversleeping? Now, I don't know if these drugs, the person that asked this, is the drugs as per weed and other drugs, or psychiatric. Okay.
All right. Did you say psychiatric, or like psychotropic medicines, or drugs? Oh, side effect of the prescribed drug. Oh, thank you so much.
Can we deal with the weed first, please?
Okay, thank you. So cannabinoid products are associated with all of the, let me just say, the entire gamut of mental illness, anxiety, depression, psychosis, and it can trigger pre-existing mental health disorders. So if you're already primed in terms of genetic loading to come up with mania, because it's genetically loaded in you, substance use can trigger the first episode of psychosis, can trigger any of these illnesses. Substance use, particularly cannabis, can also make treatment very difficult. Cannabis in particular is the gateway drug, right? So use of cannabis would often lead to use of other drugs or be associated with the use of other drugs. And listen, I know there are many people who say cannabis is natural and cannabis is from, is a plant, and that it doesn't cause any problem. See, here's my take. If you get home, Google the Boston research. So it's New England, it was published in the New England Journal of Medicine. It's called the Boston Research on cannabis. So this is a naturalistic study. So naturalistic study means it's not like in a lab. It took place over 10 years. The results came out about 5 years ago or 6 years ago. 6 years ago, if I may be wrong on that. But what they did was very simple. So they went out in the community in New England. So researchers at Harvard School, in the community around there, and they recruited people into this study. So they recruited people from age 14 to 24 who used cannabis, and they also recruited people from 24 to 35 who used cannabis. They chose an endpoint for their study. The endpoint was the difference in IQ functioning. So when you go there, one of the draw for the study was that they will offer you free psychological testing, your IQ testing. Normally will cost like $2,000. Offer it free for you. So you start out with the test, And they ask you how much cannabis you use, they document it, no intervention. 6 months later, you come back, you do another testing. 6 months later, you come back, you do another testing. And they kept on testing for 10 years. Guess what the result was? So for those who use cannabis heavily, and I'll define what the study defined as heavy, they lost 6 IQ points. 6. So let me just kind of put that in context. If you do a MOCA, and I'm sure my sister here knows what I'm talking about. So MOCA is the test that we do for geriatrics in terms of dementia. If you go from 28 to 21, you should be institutionalized. If you go from 27 to 21, you've lost 6 points. You should be in an institution. You will be in an institution because your dementia would have been so bad, right? So these kids lose, on average, 6 IQ points, and it's permanent. And then they come to tell me that, in fact, one kid was so bold, it's still in my office. She brought Purple Kush and said, "Doctor, if you try it, you stop telling me to stop." I just plugged it to my office. It's still there. More than 10 years now. So more than 10 years, who is right, me or her? I'm right, because I've seen where she ended up with the cannabis, right? So cannabis causes mental illness. It causes neurocognitive dysfunction in terms of IQ functioning. Cannabis is associated with poor school outcomes. This study, they also found out that those who are 26, 27, and 28 were not impacted. So there's something about cannabis that interferes with the normal growth of a growing brain. And in Health Canada, if you go to their website, they acknowledge it there. But it's the same government that approved it for those who are 18 and above. Why? Because they looked at the number, the dollar number. Right? That's the population that smokes it. Right? Even though they have the science, like it's a naturalistic study that has now been duplicated in Finland, in Sweden, in many other parts of the world. It's a fact, but everybody just wants to suppress it as if it doesn't exist.
Thank you very much for that. I'm sure that can be a whole different topic for another day. So how about the side effects of the medication that
Thank
we
you.
give
Sorry,
our
I forgot about that.
Yeah.
So side effect of medications. Thank you. So all medicines, particularly psychotropic medicines, they do have side effects, unfortunately. But like I always say, if you say on my right-hand side, what are the serious side effects? And on my left-hand side, what are the regular side effects, like every medicine? Most of the time, you find that the left-hand side is weighted up and very few, if any, serious side effects. The most serious side effect for antidepressant, anti-anxiety is the black box warning, which is increased suicidal thoughts. I can spend maybe another 1 hour talking about that. I personally don't take that into account at all. If I feel you need it, I'm going to prescribe it. I'm going to tell you about, this black box warning. My number is there. My secretary's number is there. Give me a shout if you think this medicine is giving you suicidal thoughts. I don't believe medicines give anybody suicidal thoughts, but I do believe if you don't talk about it, if you don't prepare the child that, listen, you may have a headache. You may feel numb. You may experience tiredness. Your appetite may go up or come down. It may interfere with your sleep. It may cause you GI disturbances. It may cause all of these little things. If you don't prepare their mind for it, they've come to you, they're dealing with more side effects now, and then they're dealing with the depression. And the medicines don't work immediately. And I hope you know that. It takes 4 to 6 weeks. So for the first 3 weeks, add all the side effects to the pre-existing condition. And children can be fatalistic in the way they think. And I think that that's where the suicidal thoughts is coming from. But if you see this child frequently and you prepare their mind for it and keep encouraging them, eventually the medications kick in. Side effects for antidepressants is a no issue. If a doctor is putting you on the older generation antidepressants, the one we call tricyclics, those ones, they can produce potentially severe side effects. You know what I tell the kids that I prescribe medicines to? What I say is, the only way you're going to die from overdose on this medicine is if you take the entire bottle and then chew the bottle as well. But I'm joking. But I'm trying to say that taking the entire bottle of 20 milligram of Prozac is not going to kill you. You'll be sick, You throw up, you have headache, you come to the hospital, we'll put charcoal, activated charcoal in your mouth, and you have to swallow it, give you some IV rehydration. You may end up in psych unit, but you're going home. Maybe the second day, third day, maybe even the same day, you're going home. And nothing has happened to you. Some of the over-the-counter medicines have more deadly side effects than psychiatric medications.
Thank you very much for that. We're coming to the end. Person is asking, if I feel I have not been heard by my primary care physician, what should I do? And that's one question. And then the other one is, how do we aid friends and family suffering from mental illness, whether they acknowledge it or not? So if they're in denial.
Thank you so much. So if you feel you haven't been heard by your primary care physician, particularly if they're not very open to referring you for one reason or the other to a psychiatrist, there are many things you can do. Okay, so across the GTA, most hospitals, and this is something that a lot of people don't know, they have what they call urgent care clinic, most psychiatric hospitals. We don't have it in Ajas, but they have it at Ontario Shores, they have it at the Lake Ridge Hospital, they have it at the Centenary site, they have it at St. Mike's, they have it at Michael Garon, they have it at North York General Hospital. How do you get access to urgent care if your family doctor is not listening to you and you want that urgent care? You don't want to wait. For example, in Ajas, it's 1 year wait time to see a psychiatrist. You don't want to wait for 1 year. So what you do is you go to any walk-in, show them your head card, and say, please refer me to this clinic. Refer me to Ontario Shores Urgent Care Clinic, or Center for Addiction and Mental Health Urgent Care Clinic. You will be seen. Within 2 months, somebody will see you, and somebody will do an assessment. And during the assessment, you can say, this is my family doctor. He refused to refer me, but please send the report to him so that he can follow your recommendations. And that way you can kickstart. How can you talk to family members in terms of support? I think that, like I said, a lot of situation is just unfortunate if you're dealing with families where there's that stigma, there's that shame, there's that information is the key. I think one way or the other, if you find your way to get seen and invite your parents to see the doctor so the doctor can answer their questions, clarify the misconceptions they may have about psychiatry, I think it helps a great deal. Sometimes you talking to your parents, maybe like, you're just knocking your head against a brick wall. They're probably not going to listen to you because they're maybe fixed in the way they feel about it. But if you are underage, you can approach your counselor in school and talk to them, and you can access services in the community through your school. If you're an adult, please talk to your family doctor. If your family doctor is not listening to you, take advantage of a walk-in clinic and get referred to urgent care clinic.
Thank you. How should students reduce stress?
Thank you very much. By doing your work on time. Okay. All right. Okay. Well, in my experience, a lot of kids really go out there and they really try. The number one reason why they derail, and I always say to the kids that I've been seeing for some time, they're in practice for a while now. So I've been fortunate to see kids from age 5, 6, 7, and now they're getting to the university. I have a little spiel, like a little talk that I give to them when they're going to the university. I call it road bumps. So I would say to you're ready to go to university now. We've seen for a very long time. This is what we've done. So what are some of the road bumps that may happen, that could happen? So we'll go through it. Don't forget why you're in school. Don't change who you are. Don't get to school and become this person that you never were. Approach your school and your studies as quickly as possible. Avoid peer-peer relationship that put too much demand on you. So we'll do all of these skills and, maintain this contact. You're 18 now, you're not supposed to be seeing me, whatever. I personally don't have a cut-off date for stopping to see my patients. Most doctors there will stop at 18. I'll continue until I feel you're ready to go. So I have people who are 24, 25, still seeing me at Shanika Clinic because they're really not ready to go anywhere yet. So my take about that is explore if there is a mental health antecedent to the stress, explore if there are lifestyle antecedents to the stress, and explore if there are learning issues to the stress. It is amazing, with a simple letter from your psychiatrist, the kind of accommodations you can get. It makes huge difference. So explore these options and take advantage of them, and they will help reduce your stress load as a student.
So the final question, and I'm so sorry if I did not get to your question. What we did, we tried to bunch up questions. So even if you didn't hear your exact question the way you asked it, we did get to it. But the final one must be from a choir member. Do you refer individuals for music therapy? And who would be a good candidate for this?
Thank you so much. That's a very good question. So absolutely, I would. There are not many music therapists around, unfortunately, and their services can be quite pricey. But music therapy is a recognized form of therapy, like one of many behavior therapies around. Do I refer people for music therapy? Absolutely, I do. I do have a place where I do refer them to. Like I said, the practitioners out there who are licensed to do recreational therapy or music therapy, they're not very many, and they're not. They're generally not. They're not covered by the public health plan. So the short answer to the question is absolutely. Music therapy is very valuable. One of the better things that I gained in training was that I worked with a lady who was one of the leading music therapists in New York. So she would come in with her instruments, and we'll have a little group like this every afternoon. And my colleagues in internal medicine and other disciplines will, laugh at us. But our stress level was way lesser than them, and in part because, every afternoon, usually from 12:10 to 12:30, we're with the music therapists and the recreational therapists and just doing our thing.
It's been such an honor, a pleasure to have Dr. Nosa here. So can we again appreciate him? And I would like to appreciate every member of the health and wellness team who came up with this idea. So if we can just appreciate ourselves. So on behalf of the health and wellness team, on behalf of the pastors, we would like to give you a little presentation. You might need to put your mic down. So, on behalf of the church, we'd like to present you with this little token. Thank you so much. Thank you.
I just want to say thank you again to this wonderful congregation. This is my church away from church. I know everybody here, and I'm sure most of you know me. I've been part of this family. Just want to say thank you once again to Pastor Victor, Pastor Pat, and all of the leaders and leadership in this church. You're also wonderful. Thank you so much for the gift and honoring me and my family.